Hello students, today we will discuss one common postoperative complication after laparotomy, especially after emergency surgery, malignant surgery for malignancy or major surgery, long time duration surgeries. So what is this exactly? So identify the postoperative complication below after an emergency laparotomy. So what is this? It is burst abdomen, also called as abdominal wound dehiscence. So word burst abdomen is the commonly used term, but the correct term is also abdominal wound dehiscence. So it is mechanical wound failure with the disruption of deeper layers of the abdominal wall. So this is the definition: mechanical wound failure. This is disruption of all layers. Remember, abdominal wall, 3 to 5% common in males. All layers is very important. Disruption of all layers. And it is postoperative separation of abdominal musculoepineuritic layer. So all layers are separated, musculoepineuritic layers. That's important. Not single, not only skin, not just skin also. So what are the precipitating factors? All these things are the precipitating factors. Remember, condition of the patient, critical patient, diabetic, immunosuppression, sepsis, peritonitis, and age, old age, obesity, cough, straining, ascites, nutritional status. Everything are precipitating factors. So what are the features? Sudden feeling of giving way. That's the most important thing. Way during straining, while coughing, like that they will cough, then it comes out. Usually 5 to 10 postoperative period. Usually after laparotomy, 7th or 10th postoperative period will give way. Sometimes abdominal content will come out. It will come out, abdominal content as such. Tachycardia, tachypnea, dehydration are the systemic features. So what is important is pinkish serous discharge. And when you palpate using a glove, dehiscence can be felt across and can be assessed very well. So put a gloved finger inside that, it goes into the peritoneal cavity. You can feel the entire, all layers are disrupted completely. So you can feel the bowel inside. Some patient, even bowel comes out during straining. So it's very typical. So pinkish serous discharge, very typical. And finger goes across the abdominal wall, so that you can feel the disruption completely. We can enter into the peritoneal cavity as such. So it is a clinical diagnosis. It doesn't require any imaging or any other method to identify. Often momentum and interest may be forced out of the abdomen across the dehiscence wound as such. So it is a clinical diagnosis, remember. So how will you manage such patient? Resuscitation, rise to fluid, nutrition, emergency surgery. Surgery is the only method. You have to do immediate surgery. So what is currently is modified bed nose closure. Olden days we used to place tension sutures with the IV drip loops and put the thread number one ethylon or nylon sutures and through the and put the knot, maybe horizontal and vertical matter sutures. So currently it is not accepted, even though many of surgeons still use it. We also sometimes we use it, but ideally modified Smith Jones far and near and far closure. So this is how exactly put. It comes like this, it goes like this, comes like this, comes like this. Then put the knot far and near. And of course, still practice these retention sutures, also called tension sutures. Now currently, even though literature-wise not well accepted, study-wise, even though many people still practice. Biological mesh placement, maybe usual traditional mesh in the infected area you can't use, Prolin mesh you can't use, even dual mesh we can't. All those meshes are used in a clean, sterile area only. So this infected area you can use biological mesh if it is available, but only thing it's very costly. But initially wound vacuum system, this is also very useful. Bogota bag, silo closure, component separation, all those things are the different method which you can use in this patient, close the defect. So once we come out of the sepsis, you can put a graft or you can redo and go different surgeries, or you can put a mesh later period. Once sepsis comes under control, it heals completely without any infection. So that is about burst abdomen. Later problem is interstitial hernia. Redehiscence is not common. Second dehiscence is not common. This is the more commonly they develop eventually interstitial hernia. Then you have to go and do laparoscopic or open mesh repair. Along with the large one, you can add on to component separation technique as such. So that is a very common entity which you come across. A common short note for you. Why you also they will ask what is a burst abdomen or emergency. You got in oxy you got a postoperative method, postoperative emergency situation. Oxy component is there for 5 or 10 marks. So these things may be asked. So you should know briefly how exactly diagnose that one, how to manage it. It's immediate immediate surgical interventions are required. Later you can manage by closure of the defect later by different methods, but at the time you have to close the defect to prevent the content to come out. That's the most crucial thing you have to remember. You can go through my surgery manual, you can go to my clinical book, you can go to operative surgery, you can read, you can go through my video lectures. Digina, entire surgery A to Z lectures are there. You can subscribe and go through that to give complete idea for you, and you can face any exam if you go through my video lectures. So students, I hope you understood small important postoperative complication after laparotomy, that is burst abdomen or abdominal wound lesions. Thank you very much.